Hello, can you hear me? Can you hear me?
Yes, sir.
Okay. Today we are going to finish the part of the previous lecture and we will try to do the rest of the peripheral nervous system today. By the way, to announce you that my lectures will be on Mondays and Fridays, right? Although the schedule says it's on Tuesday, due to my other commitments, I will do it on Monday and Tuesday. Is it okay by you? Anyway, this will last only for another maybe week or two, then you will start. Okay. Mm, Neuromuscular junction disorders are very important because they come very frequently in the MCQs and the questions, and you should be able to diagnose neuromuscular junction disorders and make appropriate referrals. Although you yourself will not start the treatment, you may need to refer appropriately. You all know about this uh, structure of the neuromuscular junction. There is this the motor end plate where there is the axons. At the end of the axons, there are these synaptic clips, and these vesicles secrete acetylcholine, which will go and interact with the neuromuscular junction on the other side of the muscle, and that will start the cascade to contract the muscles. Uh, so the commonest disorder of the neuromuscular junction is myasthenia gravis. So our discussion is mainly on myasthenia gravis today. Myasthenia gravis is an autoimmune disorder uh, which causes the destruction of or blocking of acetylcholine receptors in the neuromuscular junction. Now, if you do serology, 85% of the patients with general myasthenia gravis and 50% of the pure ocular myasthenia gravis, and we'll be discussing them later, they will have seropositivity. There are about 20%, nearly 20% seronegative cases of myasthenia gravis. They will be positive for what's called anti-MuSK antibodies, anti-muscle specific tyrosinase kinase antibodies. Now, that syndrome is slightly different from myasthenia gravis from the pattern of disability. They will have predominantly bulbar weakness and reduced response to immunosuppressive agents, and they can have a significant muscle wasting. Now, myasthenia gravis can be classified as generalized or pure ocular. So, one classification. Then they can be classified as seropositive or seronegative, and MuSK antibodies positive ones. And according to severity, they can be pure ocular, generalized myasthenia gravis, or they can be myasthenia gravis with respiratory failure. Etiologically, also it can be different, but those are not very important for your practice. So, according to severity, there can be ocular myasthenia gravis, generalized myasthenia of mild to moderate severity, severe myasthenia gravis, and myasthenic crisis with respiratory failure. Those are the classifications according to the severity. Now, etiology, as I said, is mainly acquired and autoimmune, but there can be other types of etiologies like neonatal myasthenia gravis due to passive transfer of maternal anti-acetylcholine receptor antibodies. You may have heard already of Drug-induced myasthenia gravis due to D-penicillamine, but their presentation may be identical to seropositive myasthenia gravis. There are other drugs which can exacerbate myasthenia gravis, exacerbate the symptoms in a patient diagnosed to have myasthenia gravis, like curare, aminoglycosides, quinine, procainamide, calcium channel blockers, and so forth. Uh, we have other congenital myasthenic syndromes due to mutations in proteins involved in postsynaptic uh, neuromuscular transmission. They are abnormal genes causing abnormalities in the receptor. So different abnormalities can occur at the neuromuscular junction. You must know there can be reduced number of acetylcholine receptors. There can be shortening of the synaptic cleft or synaptic fold or widening of the synaptic clefts. How are acetylcholine receptors destroyed? They are destroyed due to cross-linking of acetylcholine receptors, and then they will be endocytosed and getting destroyed. Sometimes there can be blocking antibodies blocking directly the acetylcholine receptors. There also can be complement-mediated destruction. Clinical features, again, it's very important for you to know about clinical features of myasthenia gravis. The characteristic feature of myasthenia gravis is fatigability. That is, when you keep on doing some work, the muscles get weaker and weaker. Therefore, the patients may say their symptoms are worse towards the evening. The symptoms can vary from hour to hour and day to day, and towards the end of the day, the symptoms are generally worse. There are other factors which worsen weakness, like exercise, emotional state, hot temperatures, infections, drugs like aminoglycosides, phenytoin, and local anesthetics, as we have mentioned earlier, surgery, menstrual periods, and pregnancy. What are the most commonly affected muscles? They are the levator palpebris superior, that is the muscles which elevate the eyelid, causing ptosis. So ptosis is a very common symptom of myasthenia gravis. Unilateral, it can be unilateral or it can be bilateral and asymmetrical or sometimes symmetrical. It may be partial and the ptosis may be fluctuating. Extraocular muscles are the other next muscles to affect. They will be presenting with a squint or diplopia. Proximal limb muscles also can get affected, so are the facial muscles and neck extensions. Pupils are generally spared. Did I do this part earlier in the last week lecture?
No, sir.
Right. Okay. Uh, But one thing that you must remember is any skeletal muscles can get affected in myasthenia gravis, although these are common. And the bulbar muscles is the other set of muscles which are involved in uh, myasthenia gravis. Now, sometimes there can be a weakness of the jaw due to weakness of masseter, and sometimes patient need to hold a finger below the jaw to keep the mm, jaw and the neck extended. Facial muscle weakness can lead to expressionless face and a very odd smile. And you can have palatal weakness with nasal voice and nasal regurgitation, dysphonia due to laryngeal muscle weakness, dysphagia, as I mentioned earlier, due to bulbar involvement, and sometimes respiratory failure in crisis. Most of you would know that the thymoma is associated with uh, myasthenia gravis. Similarly, thyroid abnormalities also can be associated. Other autoimmune diseases like rheumatoid arthritis, pernicious anemia, systemic lupus erythematosus, sarcoidosis, Sjogren's, polymyositis, ulcerative colitis, and pemphigus all can be associated with myasthenia gravis. So, how do you investigate these patients? Uh, Clinically, you can look for fatigability. How do you look for fatigability? You can ask the patient to keep your eyes slightly above your lid margin and ask the patient to look at the eyelids. Look at your finger, and the eyelids will slowly droop down. And similarly, proximal muscles, you can ask them to do abduction and adduction of the deltoid muscles, and then examine him before the exercise and after exercise. If there is a weakness after exercise and it improves with rest, fairly suggestive. Ice pack test also is one way that you can demonstrate, especially in ocular myasthenia. Sorry, if you keep ice over the ice, that is over the ice of the patients, you keep a pack of ice, and the patient symptoms improves. Endophonium was a very useful test, but for some reason Endophonium is removed from the formulary and is no longer available in Sri Lanka and in many other countries because of the fear of side effects. Now, if your Endophonium is a cholinesterase inhibitor, short lasting, so that it's an ideal drug to test. You give IV dose after initial small dose, and then there will be accumulation of acetylcholine and the patient improves and it disappears within a few minutes, like 20-30 minutes. But for some reason, endophonium is not available because they can have bradycardia and sometimes cardiac arrest. We have never experienced that because we always pre-medicate the patients with atrophy. Acetylcholine receptor antibodies are commercially available, and anti-musk antibodies should be done in appropriate cases because these are very expensive tests. Acetylcholine receptor antibodies will cost about 6,000 to 8,000 rupees. Repetitive nerve stimulation is what is shown here, and with repeated stimuli in a normal person, all the uh, The repeated stimuli will produce amplitude of the same magnitude. Whereas in the one on the right, you can see in a patient with myasthenia gravis with subsequent stimulation, the amplitude of the action potential will be less than the previous one. So giving a decremental response. Uh, Another method that can detect Myasthenia gravis and some other neuromuscular junction disorders is also called single fiber EMG. Here there is a very fine needle which will measure theoretically, at least as we assume, action potential of two adjacent muscle fibers. Normally, with repeated stimuli, all these subsequent that stimulation is done with the finger movements. Subsequent movements will produce the action potential one over the other. They are not spread. But in the case of myasthenia gravis, they will be subsequent stimulation will produce widely separated time intervals between the action potential. So this is a clear indication where there is a neuromuscular junction disorder. So single, if we ask one of the name one investigation, if you just write EMG, that is wrong. It should be single fiber EMG because the technique is completely different. Now treatment, we start with acetylcholinesterase inhibitors like neostigmine and pyridostigmine. As I mentioned earlier, Endophonium was used as the like to test whether it's a myasthenia gravis. When you are giving neostigmine and pyridostigmine, you must make sure that you give the appropriate dose. With increments of the dose, they can get cholinergic symptoms like salivation, sweating, muscle cramps, and all that. Acetylcholinesterase inhibitors like neostigmine and pyridostigmine can be taken orally and are very effective in symptomatic relief. Neostigmine, however, should be given very frequently, at least 4 hourly, they say. Pyridostigmine can be given twice a day. Corticosteroids are always useful, and you can give prednisolone 10 milligrams to 60 milligrams a day, 10 milligrams generally for ocular myasthenia patient, and 60 milligrams per kilogram body weight, 60 milligrams a day for big people with generalized myasthenia gravis. But to get the effect, it will take about 2 to 4 weeks. Now, you all know, or very well know the side effects of prednisolone and the problems. So that you have to use the other agents like azathioprine, cyclophosphamide, MMA for methotrexate as a sparing steroid sparing agent. Uh, okay. Now there are patients who do not respond to pyridostigmine and prednisolone and immunosuppression and sometimes go into what's called a myasthenic crisis where they get a weakness of the muscles, they are immobile, neck flexion will uh, appear and then the patients can go into respiratory failure. So this type of patient need quick treatment to come out of this myasthenic crisis. And plasmapheresis is effective in improving these patients. Immunoglobulin is equally effective, IVIG. Now, plasmapheresis or immunoglobulin can be given in two other situations. Like before thymectomy, the patients may need, especially poorly controlled ones, may need immunoglobulin, immunotherapy. And uh, sometimes immunosuppressive therapy will take, not sometimes, immunosuppressive therapy will take several weeks. And in that case, we can use them use plasmapheresis or IVIG to bridge that period. Many patients with generalized myasthenia gravis will be benefited from thymectomy. Now, thymectomy will be very successful and relieve symptoms if the patient has generalized myasthenia gravis and if the pathology is thymic hypertrophy. But that cannot be differentiated by imaging. Anyway, you have to remove the thymus. So thymoma, if the patient has thymoma, anyway, we have to remove the thymus because it's a thymoma and locally malignant. But the myasthenia gravis in patients with thymoma will not respond very well to thymectomy. So it is indicated, especially the thymectomy, young patients with generalized myasthenia gravis for symptomatic relief. Right. Then we are now going up in the ladder from muscle, neuromuscular junction, nerves. Now we are going to anterior horn cell diseases. Anterior horn cell diseases by definition are degenerative diseases of the motor neurons. And there's a degeneration of the anterior horn cell. Because anterior horn cell they can involve the upper motor neurons or lower motor neurons, depending on the mixture and admixture. So depending on the mixture of upper motor neuron and lower motor neuron involvement, you get different patterns. There are several common things like ALSO, amyotrophic lateral sclerosis, where their patient get weakness of the upper limb and wasted, and then their reflexes may be absent, and subsequently they get spasticity of the lower limb. Now, if there is a patient with upper limb weakness and flaccid lower limbs, what is the common diagnosis that you would think if a young person comes? Hmm? What will happen in cervical cord compression? So, if the patient has wasting and weakness of the upper limb and wasting uh, and spasticity of the lower limbs, you have to first think of cord compression, cervical cord compression. But if there is a widespread fasciculations in the upper limb and lower limb, indicating that there is a mixture of upper motor and lower motor signs in the without a clear spinal cord pattern, then ALS is very likely. They can present with bulbar palsy, where there is difficulty in swallowing and difficulty in speaking, or dysphagia and dysarthria. They can have pseudobulbar palsy. Pseudobulbar palsy patients will have a spastic tongue, so their speech will be dysarthric. They, they can have uh, drooping of saliva, and they have an emotional lability because the upper motor control is gone. And of course, there's another variety called progressive muscular dystrophy or atrophy, where there is a wasting of the distal muscles commonly, but the muscles will get atrophied. They generally do not have upper motor neuron signs. So different combination of patterns of physical signs can be there in a patient with anterior horn cell disorder. But you must remember one thing: in a young patient with doubtful physical signs and doubtful diagnosis, we don't label them as MND or ALS, because that is like giving a death sentence undated or dated 3 years ahead. So we don't do that. We have to, in those cases, we have to confirm it in the laboratory before we talk to the patients. Now, you will understand that many other illnesses also can mimic anterior horn cell disorders or motor neuron disorders. Now, in anterior horn cell disorders, muscle wasting is painless and generally starts in one limb and then spread to the other contralateral limb and then progress to the other limbs. The they should be suspected when there is a problem of speech and swallowing, especially swallowing when there is no structural obstruction. So, speech problems or swallowing with wasted or low motor neuron signs in the limbs can be a feature of MND. Progressive muscle stiffness and spasticity and muscle cramps and fasciculations are also known with MND. But one thing to remember is these signs in isolation and very occasionally do not constitute MND. Many third year medical students come to us when after they have studied MND asking whether it could be MND. They're just muscle twitches are not fasciculations. Fasciculations are the muscles moving like a bag of worm, and and just one muscle twitch is a muscle twitch rather than a fasciculation, right? And in any case, just the fasciculation does not always indicate the anterior horn cell. It can be due to axonal damage from any cause. Some people have progressive muscle stiffness and spasticity, and those can have muscle cramps and fasciculations. And unexplained restrictive lung disease with a pattern suggestive of diaphragmatic weakness also is another presentation. Some people get their head drop. I can see some of you also get a head drop now. But this is just there when they are very well awake. Also, there could be a head drop and trunk weakness of the trunk and paraspinal musculature with upper motor signs. There are different criteria to diagnose and MND, motor neuron disease, but you don't have to remember one by one. One thing that you have to remember is that lower motor neuron in the upper limb and upper motor neuron in the lower limb. First, you have to exclude spinal cord disease, spinal cord compression or spinal cord disease. The other way, if the lower motor neuron signs are there in the lower limb and upper motor signs in the upper limb, then that could be a case of MND. Anyway, general advice is general advice is for you to confirm the diagnosis before you uh, tell the patient. Sorry about this. I am trying to get. Right. So, if the patient has uh, lower motor signs in the lower limb and upper motor signs in the upper limb, that's fairly definite, especially if there is a involvement of the tongue. But the other way we mentioned that it is unlikely to be a motor neuron disease because it can be explained on a cervical cord compression. Uh, Now, there are situations where we are not sure. There can be low motor neuron signs in the upper limb, as I said, and upper motor signs in the lower limb, but there are no low motor signs in the lower limb. In those cases, neurophysiology, that is EMG, will be useful, and EMG will EMG will show very large motor units, which I will show when you come to the boards for your clinical work. That is on the EMG. Now, one presentation we said is the bulbar palsy. Those patients will present with dysarthria, dysphagia, and pseudobulbar palsy patients will have upper motor neuron signs in the lower cranial nerve bulbar muscles. That is due to the involvement of the upper motor neuron. Upper motor neuron also can be involved uh, in motor neuron disease. Diagnosis is by EMG, but EMG also you have to demonstrate that there is a widespread denervation in muscles involved in the cranial territory, upper limb, lower limb, and trunk. So at least you have to demonstrate 3 out of 4 regions which are not contagious. For example, if there is uh, tongue and trapezius muscles, there may be some regional thing like a syringobulbia also can explain that type of thing. There is no specific treatment for motor neuron disease. The patients will eventually die, but there are restricted. There are other more anterior horn cell disorders like DSMA, distal spinal muscular atrophy, which is common in Sri Lanka. You can have a wasting of one muscles, which can spread to the other muscles, other side, other hand, and then they stop. There's non-progressive. But if you diagnose MND, that is meaning that there is denervation of the upper limb, lower limb, and cranial nerves, prognosis is very poor. And there is one drug called Riluzole, 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 which will prolong the life by maybe 3 months, something like that. Not very beneficial. So it is important for the when once you have confirmed the diagnosis, it is important for you to talk to the family and say, this is this, and well, you can get a second opinion, but not to go all over the country seeing all the neurologists and spending your money. That money can be used to improve their uh, activities of daily living. And talking to the family, you have to be very careful. You are going to tell them of a disease which is going to be fatal in 3 years. So you have to understand their emotions, and that part also need to be reinforced when you are talking to patients in when once the clinicals are started. Of course, if there's any suspicion, Whether this could be spinal cord disease rather than anterior horn cell disease, you must always do MRI scanning. I mentioned about the DSMA. It's better for you to know because in a short case, if you get a patient with a small muscle wasting of one side, asymmetrical, sometimes asymmetrically about both sides, especially with involvement of the small muscles of the hands and sometimes part of the forearm. The diagnosis may be, if there is no sensor loss, diagnosis may be distal spinal muscular atrophy. So uh, you must be aware of this diagnosis. Although it's an anterior cell disease, as I mentioned earlier, there is no long-term prognosis is good. We go to the next section of the peripheral nervous system lecture. This again is very important in your short cases and in your MCQs. We have discussed this. Okay. Between the anterior cell disorders and the anterior cells and the neuromuscular junction is the nerve neuron. So diseases of the neurons can be either neuropathies or radiculopathies. Neuropathies can be either mononeuropathy involving a single nerve, or it can be peripheral neuropathy involving multiple nerves. Sometimes single nerves can be affected at different places. Different single nerves can get affected at a given time without being a generalized disorder of the nerves. Those are called multiple mononeuropathy or mononeuritis multiplex. Now there are so many nerves, peripheral nerves in the uh, body, and you may not be able to discuss all the nerves, but we'll be discussing some of the important nerve policies in the latter part of this lecture. Now, we earlier also we discussed that peripheral neuropathy will have a asymmetrical or distal symmetrical weakness and sensory loss. Sensory loss, therefore, would be like a so-called stockings and glove type sensory loss. Depending on the involvement of the motor, sensory, or mixed nerves, they can be classified as motor neuropathies, sensory neuropathies, or mixed neuropathies. Commonly, they are mixed neuropathies. The modalities of sensory loss also may be different in certain neuropathies. We'll discuss them later. Other presentations would be neuropathic pain. They get a very severe burning pain, especially at night, or severe aching type of pains at night. This is very common among patients with diabetes mellitus. Due to the sensor loss, the patients will have ulcers, non-healing trophic ulcers. And certain illnesses you can have thickened nerve like in leprosy, CIDP, and diabetes. So this is one of the MCQs. Thickened nerves are seen in leprosy, CIDP, diabetes mellitus. Then they will give some axonal neuropathies, which where there is no no nerve thickening. Skin rashes and neuropathy is common with and in the West. So then we have hereditary neuropathies, earlier called Charcot-Marie-Tooth disease, but now they are called hereditary sensory motor neuropathy. Lepers we mentioned, and nutritional deficiencies are fairly common cause, especially B12 deficiencies are now becoming commoner in the population. One of the reason is the drugs like metformin. Diabetes has gone up. Apart from diabetic neuropathy, they can have due to drug metformin, the absorption of B12 will be poor, and B12 neuropathies they can have. B1 thiamine also can cause neuropathy, and B6 and vitamin E deficiency also can cause peripheral neuropathies. B1 neuropathy again is common among poorly nourished people and and alcoholic patients. Vasculitis is another fairly common cause, like systemic lupus erythematosus, rheumatoid arthritis, polyarthritis nodosa, and vagus all can have peripheral neuropathy as part of the illness. Another important one is essential cryoglobulinemia. Toxins like organophosphates, heavy metals, and drugs like INH, anti-cancer drugs are well known to produce peripheral neuropathies. Certain long-standing metabolic derangements like chronic liver disease and chronic kidney disease can lead to peripheral neuropathy. Okay, now you must know the common causes, but the common questions come from uh, Guillain-Barré syndrome. You must know in and out of Guillain-Barré syndrome. Incidence of Guillain-Barré syndrome is also called acute inflammatory demyelinating polyradicular neuropathy. Now, earlier it was a demyelinating neuropathy, but now we know that there are, apart from the demyelinating neuropathies, there are axonal varieties, but still the name remains. Incidence is about 0.6 to 4 per 100,000 worldwide, and in Sri Lanka we calculated, and it's about 2 per 100,000 population. 1.7 rather, yeah. It's an immune-mediated neuropathy, and some people call it acute immune polyradicular neuropathy. Associated Campylobacter jejuni gastroenteritis is a clear association, and we know how it occurs, and it is due to the antibodies against the Campylobacter acting on the Ronnier nodes of the myelinated nerve fibers. Upper respiratory tract infections, especially viral ones, are known to uh, produce Guillain-Barré syndrome. Certain vaccines like uh, influenza vaccine and paraneoplastic syndromes can also produce syndrome like Guillain-Barré syndrome, and now we know that HIV can also cause patterns similar to Guillain-Barré syndrome. And it's called polyradiculopathy because it's the pathology is mainly in the proximal part of the nerves, in the nerve roots. Roots are called radicals, so it's called radiculopathy because polyradicular neuropathy because it's not only the nerves, the nerve roots are the first one to get affected. You will understand when I discuss the investigations how it is important. characteristic feature of Guillain-Barré syndrome is that there is a subacute onset. And mind you, I forgot to mention this in the beginning. It's a very common exam question. The maximum disability will be developed over 2 to 4 weeks, and then they recover if there are no other problems or complications. Although they say up to 4 weeks, generally by about 2 weeks they get the maximum disability. There will be a flaccid weakness of muscles. In definition, they say more than one muscle. Generally, all four limbs are weak. The involvement of the nerves is proximal as well as distal. Generally, there's no, you cannot say proximal more or distal more because generally they are equally weak. There is significant hyporeflexia or areflexia, not only in the weak muscles, weak limbs, in the unaffected limbs as well. Another common feature would be a lower motor neuron bilateral facial nerve palsy, where the patient cannot close the eyes tight. And that is with the limb weakness is very, and if there is subacute onset, all four limbs weak, and there is a bilateral facial nerve palsy, and the patient conscious, means that it's very likely to be Guillain-Barré syndrome. Another differential diagnosis was called a Lyme disease, which is uncommon due to a tick fever, but that's uncommon in Sri Lanka. About 25% can go into respiratory failure, and that will indicate a poor prognosis. And about 15% can get autonomic dysfunction again. They get cardiac arrhythmias, hypertension or hypotension, ileus, paralytic ileus, or urinary retention. Patients can have sensory symptoms like pain and sometimes numbness and tingling of the extremities. But there is no objective sensory loss. So when you suspect a patient, you must investigate them. Of course, theoretically, nerve conduction would be the best. So because it's a demyelinating neuropathy, the nerve conduction velocities will be slowed, and you can see the distal latencies will be delayed, and the nerve conduction velocity will be slow. And the F wave, which is generally due to the impulse go up retrogradely into the anterior horn cell and coming back. So that measures a longer part of the nerve, and so that will be prolonged early. So that's an early sign. CSF analysis when we do around 10th day, and there will be raised protein with no or very few cells, and this is called cytologic albuminocytologic dissociation, and it's considered as a fairly significant finding to diagnose Guillain-Barré syndrome. But again, in some cord compressions with obstruction, you can have raised protein with no cells. Anti-GM antibodies can be positive, and different patterns, different subtypes of Guillain-Barré syndrome will have different antibodies being positive. If the patient is very ill on admission, you have to check your famous ABC, especially the ventilation and the blood gases. And while the patient is being monitored, you have to look for respiratory failure, autonomic failure, deep vein thrombosis because they are weak. They can develop contractions, but contractions are generally uncommon with lower motor neuron weaknesses. Some patients will remain with a residual weakness. And of course, if they happen to be ventilated, then they have all the complications associated with ventilation and bed-bound state. Although we said it's AIDP, acute inflammatory demyelinating polyradiculopathy, we have identified axonal varieties, especially in China. China has all sorts of odd things. And They exhibit more rapid than severe course and the prognosis generally poor. They get respiratory involvement more frequently and the cranial nerve involvement also is known. They can have autonomic involvement, but it is uncommon and mild. There's a variety called AMAN, acute motor axonal neuropathy. It's a pure motor syndrome with rapid onset muscle weakness and absent reflexes, and the neurophysiology shows an axonal pattern. AMSAN is characterized by presence of both motor and sensory deficit and axonal pattern. There is another syndrome called a Miller-Fischer syndrome. This also may be important for your MCQs. It has ophthalmoplegia, areflexia, and ataxia and other cerebral signs. Sometimes there may be overlaps between Guillain-Barré and Miller-Fischer syndrome. Then there's another entity called a Fischer-Bickerstaff encephalitis. They can have Fischer syndrome, that is ophthalmoplegia, areflexia, cerebral signs, one or more of those, with an encephalopathic illness where the patient is drowsy and sometimes can go into respiratory failure. As I mentioned earlier, the infection can lead to antibodies due to molecular mimicry. They can damage myelin. And then there's accumulation of macrophages and mononuclear cells in myelin sheath, and uh, that lead to uh, the AIDP, and they are collected at the Runnier nodes in AMAN, acute motor axonal neuropathy. Uh, Treatment would, as you would know, IVIG or uh, immunoglobulin or plasma exchange. Uh, okay, why why it has a fairly rapid uh, onset is debated, and now we know that these antibodies can sometimes block voltage gated sodium channels, but those antibodies can be neutralized by uh, IVIG. Patient needs specific therapy with either plasmapheresis or immunoglobulin. They improve the disability, clinical features. They reduce the need for ventilation, which is very beneficial for countries like ours. Benefit is greatest if we have given early, and that is where the investigations will need to be discussed again. Now, we mentioned that nerve conduction velocities are the or the about the lumbar puncture and nerve conduction studies. Now, nerve conduction studies can be normal in the first week because the pathology is happening in the proximal muscles. And if you have seen nerve conduction studies, that we will do in the distal part of the limb. So, early studies will not catch the delay in nerve conduction. However, there are other techniques like F waves, as I mentioned, where we stimulate the nerve the other way so that the impulse will go to the anterior horn cell and come back. Those can be delayed early because it's a longer stretch. My famous example is when you are traveling to Colombo, and if somebody is driving at 80 kilometers per hour and the other one is at 100 kilometers per hour, initially the gap is very, very small. But when you reach Colombo, of course, the 80 kilometers per hour person is not to be seen, so slow. So although when the length is more, you can see the delay, and that is the basis of F waves detecting the abnormalities early. So, and the CSF analysis also can be done on the 10th day. So there is no way that we can confirm the diagnosis on the first week. Therefore, it is very important in a patient with flaccid paralysis to find out what are the possibilities that will point to the diagnosis of Guillain-Barré syndrome and the possibilities that may indicate otherwise, like acute cervical cord compression, acute myasthenic crisis, periodic paralysis. They also can present with fairly acute weakness of the limbs. So apart from the specific management, the general management should be done by a multidisciplinary team with nursing staff playing a big role by monitoring and ICU care when the patient is in ICU. If the patient has autonomic dysfunction, you have to give appropriate drugs. Vital capacity should be monitored, and in patients who have weakness and unambulant, DVT prophylaxis should be given with subcutaneous enoxaparin and compression stockings. Urinary retention, bowel dysfunction, and pain need to be managed. Pain generally respond very well to things like amitriptyline or gabapentin. Rehabilitation should be done once the patient is out of the risk of having respiratory failure or other important medical complications. Many patients, most of them recover 10 to 20% left with disabling motor deficit. Generally, what they say is 90% recover 90%. 4 to 15% of patients die by 1 year after onset. Older age, severe disease at the base, rapid onset of disease and association with Campylobacter is uh, known to have a poor prognosis. Axonal loss in the neurophysiological testing also indicate poor prognosis. Right. Any questions on this? No questions. So we will continue with this regardless of the timetable next time. Next lecture will be on Monday at 2 o'clock. Okay? No
Sir, we
questions.
have a term exam.
When is that?
We're starting on the exams from the 13th and 14th. It's in the evening as far as we are informed so far.
Right. So I think you will be studying on those days. So we will have it on a different day. Just
Okay.
let. So it's going to be for 1 day or how many days?
So we have three subjects. So I think pharmacology is on Monday, Tuesday we have forensic, and Wednesday most probably community medicine.
So I'll tell you, I can give you those 3 days free,
Okay.
provided you can come for lectures on Thursday and Thursday. Of course, I have like. Then Friday, shall we do 2 lectures? If
Oh,
that if that is possible, I can give you a 3 free days for your test. Okay.
okay. So next Monday, as in the 13th, right? We're starting on.
Next Monday is actually not 13. Next Monday is
Okay.
next Monday is
Sorry,
6th,
sorry.
no?
Yes, we are starting on the 6th, but I think like we have some practicals and lectures from next week onwards. So far,
Right.
only from Tuesday. We
Right.
weren't
So
told.
we may be able to do it in the lecture. I don't think it's possible because that's open only for the third MB, isn't it? So
So we are that batch, sir. We are having some lectures in the hall.
you have lectures in the hall, but the decision was to do
Yes,
only the
yes, sir.
pathology and what
Yes,
lectures
we
required for
have
the
those.
exam.
Yes, sir.
Anyway, because I will be on leave from in September, so
Okay.
I have to finish this. But anyway, we can do it. Would you mind having lectures after hours? That's all. Anyway, we will see. First, you so next week also you will have your practicals, indeed.
They are doing the ones that we had to complete before the exam. Everything from next week onwards.
Mm.
With part two.
Anyway, I will ask from the department also. Anyway, I can finish the neuro lectures.
Yes, sir.
It's a matter of we are having another 2 or 3 lectures, but as I was running slow, I have some leftover stuff to talk to you. Yeah, I'll discuss with the head and let you know. So
Yes.
next week we'll take it as you don't have. Uh, anyway, you cannot do lectures, no? Except in the morning. Morning, will you be free?
Sir, we haven't been given a proper schedule, so maybe you can contact our batch rep and just check
Yeah,
with him.
yeah,
If it's
yeah.
just an
Okay,
hour, I'm sure it can be fit in because
right.
it's a Zoom lecture. So just contact him. He'll be updated on the schedules, I think.
Okay, okay, right. Thank you. So
Okay.
hopefully next week we may not have lectures. And some other before I go on leave, I will finish a neuro lecture. So that's my responsibility. Huh? Right.
Okay, sir.
Okay, right.
Thank you, sir.
Thank you. Bye.